move that the sitting be now adjourned.
The question is that the sitting be now adjourned. Mr. Paul Maynard.
Yeah. Thank you, Mr. Speaker. It's a pleasure to serve under your chairmanship today. It's a pleasure to see so many in the chamber. An example, I think, of how important this issue is to so very many people. I'm very pleased to have secured this debate at what is a crucial time for people with epilepsy. Crucial, I think, because of some of the uncertainty that exists around how the government intends to treat the condition going forward. We are going through a period of structural reform in the NHS, reform that I strongly believe will lead to substantial benefits for very, very many patients. However, there may well be a temptation during that period of reform for the Department for Health to concentrate on the structural reform and maybe not so much on individual conditions like epilepsy. I want to spend today trying to explain to the Minister why he thinks he should focus on particular chronic conditions and not just on the bigger picture. And I think in particular, I would very much like to explain to him why I think epilepsy is actually quite different to very many other chronic conditions. As someone with epilepsy myself, I also have another chronic condition, cerebral palsy. The cerebral palsy is part of my life, day in, day out. It never goes away. It's always there, and I know it's there. Epilepsy is qualitatively different. I often liken it to a thief in the night, because it creeps up on you, unexpected. Certainly in my case, as I have nocturnal epilepsy, so it affects me when I fall asleep, and the chemicals in my brain do whatever they do, and a fit occurs. In my case, triggered by alcohol, so I now have to avoid alcohol continually everywhere I go. But I think what it is important to stress, and what I think many without epilepsy may not realise, is the fear that accompanies epilepsy. I do not fear my cerebral palsy, because it is predictable. I know it is there. I know what is occurring. But with the epilepsy, when I wake up the next morning after a fit, I do not know who I am. I do not know where I am necessarily. My short-term memory has gone. I can't quite put together what I did the day before, where I was. Even now, I'm not really sure where I am in the country. I fear the fact, what has happened to me overnight? Have I soiled myself? Is there a mess on the floor? Am I going to need to call for help? And the embarrassment that that might accompany with it. So I think it's very important to stress to those who don't have epilepsy, the fear that accompanies a fit. The fear that accompanies the aftermath. It isn't the fit that is the unpleasant thing for those of us with epilepsy, because we don't experience it. We are not there. It's the aftermath, the dealing with the consequences that are often the problem. And I think for many people with nocturnal epilepsy, perhaps the biggest fear is something called SUDIP, which those without much familiarity with epilepsy might not be aware of, but it stands for sudden unexplained death from epilepsy. Almost 1,000 people a year die from epilepsy, many of them in the younger age groups. 2/3 of them are avoidable. It particularly affects young people as well. Yet, one survey by Epilepsy Action found that 33% of primary care trusts lack a transition plan from childhood to adult care, which I think is vitally important, that when you move from one to the other, that's your period of greatest vulnerability in my view. And many of the tragic cases that I've received and have been written to about, and I know many other members in this room have, deal with the issues of young people who 1 minute are living a happy, normal, daily life, and suddenly, one night, they go to sleep and they do not wake up. That, to me, is a great tragedy. There needs to be a particular focus on the better provision of quality of data regarding children's epilepsy and transition care to see if we can start to tackle that. If we could only match the median death rate for the 15 original EU members, for example, we could save 1/4 of the deaths that currently occur. If this were a single transport accident, we'd have a public inquiry tomorrow. That becomes something of a cliche these days, but the numbers we're talking about here are substantial, and I do believe that we can be making progress. And it isn't, in my view, just about the human cost either. It's also about the financial cost. I'd like to focus on particular on the issue of misdiagnosis. In the view of Epilepsy Action, some 20 to 30% of cases are actually misdiagnosed at a cost of 140 million to the NHS. I know this from personal experience. When I first started having fit, when I moved down to London in my early 20s at night, I didn't really know what was happening to me. I just thought I was falling out of bed, but there was blood everywhere, and I couldn't quite put two and two together. There was one evening where I sufficiently threw myself out of bed that I banged my head against my bedside table, and I had quite a deep cut between the eyebrow and the eye, missing taking my eye out by the narrowest of margins, and it was quite a deep cut. My next door neighbour said, "I really think you ought to go and get that seen to." I didn't want to because I couldn't really explain what had happened to the nurse, but I pootled down to the hospital anyway, and the attitude of the nurse was, "You've been drinking, haven't you?" And that is a classic example of, to my mind, misdiagnosis. A chance to diagnose me with epilepsy, to start me on a treatment plan, was missed because there was a presumption that somehow I had been drinking and that it was a cause of drunkenness. So misdiagnosis, it affects at every stage of the process, in my view. There are apparently some 74,000 people who are diagnosed with epilepsy, but who don't actually have it. Now, not only does that have a cost in terms of the drugs they are on, but it also has a human cost in terms of the stigma they feel they have to bear, the worry they have in their daily lives. So, if they could only be diagnosed not just with what they don't have, but what they actually do have, that would be an improvement for their lives. We also have 69,000 people who actually have the wrong type of epilepsy diagnosed. I went into quite some detail about the type of epileptic fits I have. There are some 40 different varieties, I gather, of epileptic fit that can affect an individual, and they all need slightly different treatments. So I think it's actually quite important that we get the correct diagnoses, and this is why I think specialisms matter. It's why epilepsy is special, and why I plead with the Minister to regard this as a special type of chronic condition. That's not to say other chronic conditions don't matter or aren't important, but epilepsy is quite different to very many others, and it needs to be treated in a special way. And that means having special GPs. I was fortunate. When I was first diagnosed, I had a GP who was interested in epilepsy. When I moved house, my next GP wasn't interested in epilepsy quite so much. So the nature of my treatment, of my care, changed. The quality of that care changed. What I hope we have in the formation of local commissioning groups is the opportunity for GPs to develop those specialisms, to build on those interests, not just in epilepsy, but in the very many other specialist areas that people regularly go to the GP about. I really think that local commissioning groups are an opportunity to advance that agenda, and I urge the Minister to explain to us how he thinks local commissioning groups can develop those specialisms. I think it's worth pointing out there was a all-party group report back in 2007 now, 3 years ago, but there was a fantastic quote in it from someone called Dr. Hannah Cock, who was at St George's Hospital, senior lecturer. Unless patients with long-term epilepsy at general practice level are in crisis, they do not get referred. I think that's a very important point. It shouldn't have to wait for a crisis to occur for people to get the treatment they most need. I know President Obama's recently retired Chief of Staff is known for saying, "Never let a good crisis go to waste." I think when it comes to epilepsy care, we don't want to get to that crisis point. We want to have consistency of care, and that consistency, I think, is also very important. I'd like to raise in particular the issue of generic substitution, which might sound rather arcane once again to those who aren't familiar with it, but I, like many others, take a regular dose of medicines, of tablets. I go down to my pharmacy every 6 or 8 weeks to pick up my new set of prescriptions. Wonderful. I have no problem with the idea of substituting generic medicines. I think it's important that we get value for money and effective medicine. But where I do have a concern, and where I would ask for reassurance from the Minister, is that I want consistency of supply. Because whilst the name on the packet might be the same, if it comes from slightly different manufacturers with a slightly different compound that just alters ever so tiny weeny ways, it can have a massive impact on the way my brain reacts when various things occur in it that may lead to fits. So consistency of supply is my concern when it comes to generic substitution, not the very idea of generic substitution in itself. I know the department is engaged in a consultation on this, but I would ask, for the sake of the very many people like me who are quite worried about this, for some degree of reassurance. The other aspect of consistency that I think the Minister can offer some comfort on is the issue of specialist nurses. I think they are a wonderful idea. I know Epilepsy Action has been campaigning to promote their virtues. They refer to them as sapphires. They do have an important role to play. We have about 250 at the moment. The best estimate of the number we need is actually 1,100. So there's clearly a gap. The problem also being that those who are retiring or leaving aren't actually being replaced at the moment. So the shortage is going to continue further. I know that the last government recognised the importance of these sapphires and was going to do a study into their effectiveness. I'd like to ask the Minister for some reassurance that the current government will actually go ahead with that and does recognise their importance. Specialist nurses are a cost-effective means of providing consistent, low-cost care that actually monitors over time the condition of a patient and makes sure that any blips in the radar, as it were, are picked up early without needing more costly intervention further down the line. Because that, I think, is actually the crucial point. Better care, better treatment is actually more cost-effective. And at a time when we're all, or at least I hope we are, all looking for ways to save money, I think that actually this is one way of achieving it. Because what we don't want is inadequate care at the primary care stage that then leads to more expensive tertiary care at a later stage. We don't want crises to occur. Cheaper care actually occurs in a primary setting and helps individuals manage their condition, puts the patient in charge of their condition, in my view. However, we do need more specialism, and I use that word again, special, at a tertiary level. Neurological consultants are thin on the ground as it is. Neurological consultants with an interest in epilepsy are even thinner on the ground. They are one way of helping to correct existing misdiagnoses. They will help get it right first time as well and stop those misdiagnoses. Yet, I gather from another Epilepsy Action survey that 90% of primary care trusts are not meeting the recommended 2-week deadline to getting to see a consultant. Now, I say that with a degree of caution because I am no fan of 2-week deadlines, artificial, lacking in clinical sophistication, robbing clinicians of their own clinical judgment. I have never been a fan of the 2-week deadline. However, it does have something slightly more, in my view, than a decorative role. It's only because when a lot of people present to their GP, they are presenting because the crisis that I was talking about earlier has occurred. There does need to be some degree of urgency of referral, particularly because I do hear very many stories where the referral has occurred and then the patient has died as a consequence before he has actually seen the consultant. That is a tragedy and an avoidable tragedy. So I would urge, we don't need artificial deadlines, we don't need artificial targets, but there does need to be some way of ensuring that urgent cases can be referred promptly and be reasonably confident that they will see a consultant in a reasonable period of time. I also want to ask for a bit of special treatment from a national level. I would be very interested to hear whether the Minister might consider creating the position of a National Clinical Director for Epilepsy. I know it's been a long-term demand of many organisations within the Joint Epilepsy Council because one can commission at a regional level very successfully, in my view. And it has occurred in many parts of the country for many chronic conditions. But I do believe you need to have that degree of national oversight that just makes sure that standards are set and standards are adhered to. I do realise that we have clinical guidelines set by NICE, but I do have my concerns. Before I came to this House, I was fortunate enough to be the parliamentary candidate in Twickenham in 2005, not far from the Minister's own constituency. And I wrote a letter to the local paper because it was National Epilepsy Week and I wanted to highlight the issues. And someone wrote back in the next week to say, well, clearly I was possessed by evil spirits. Now, I thought Twickenham and South West London were a particularly liberal, enlightened part of the world, I was always told. They were so sophisticated, they had discovered liberal democracy a few years earlier than the rest of us. However, I think evil spirits was perhaps a bit unfair on me, but I think for many patients, it's almost like nice clinical guidelines are a bit like spirits of a sort. They don't have any real substance or tangible meaning. They aren't mandatory. I know there's always a big discussion over whether clinical guidelines should be mandatory because we don't want to take clinical power away from the consultant. But once again, consultants and clinicians are frustrated they can't implement these guidelines. Equally, patients are disappointed that these guidelines actually don't mean anything in reality. So I do think that there is perhaps more of a philosophical issue to be dealt with here, which is if we aren't going to have clinical guidelines for any condition perhaps, how do we deal with the fact that clinicians need to be reasonably confident that they are supposed to implement them and patients confident that they will mean something? There is no point having them as decorative features. They're not a Christmas tree. They're actually meant to help clinicians give better treatment. When the last government met with the Joint Epilepsy Council, the then opposition spokesman, Noel Howe, to whom I pay immense tribute, and I know how much he has done for epilepsy. I worked with him for many, many years, and he's a very good man, and I, more than anyone, am delighted to see him as a minister at last. When he met at the conference of NHS commissioners that was held, he said to them to go away and make a difference. I would quite like to get a specific answer from the minister at how he thinks NHS commissioners are now making a difference. I think in particular, I would make a plea to him. Will he agree to meet with me and representatives of the epilepsy charities, the Joint Epilepsy Council, Epilepsy Bereaved, Epilepsy Action, as well as senior clinicians to discuss some of the fundamental concerns that the sector has? As I said earlier, better treatment, better care will lead to improved cost savings for the department, but more importantly, an improved quality of life for the some 400,000 people in this country who actually have epilepsy. I was quite surprised to read that in my own constituency of Blackpool, that PCT has the highest incidence of epilepsy in the country, something I hadn't realised, certainly. So we're not talking about small groups of people here. We're talking about large groups of people who have to deal with an immense stigma in their lives, as I know some of my honourable friends are going to talk about. We have to deal with this day in, day out. It is unlike any other chronic condition, in my view. So I thank the Minister for listening. I thank my colleagues for attending. And please, can we hear some good news, some positive news about how he intends to take this agenda forward? So thank you very much.
Yeah.